Thank you, Marty. What a fascinating lecture, and really important. So I'm going to come to you with my first tough question, which is your early evaluation of what to do with these very young patients with symptomatic severe aortic stenosis in the ages, around 50s, et cetera. And your diagram showed us TAVR first, then TAVR/SAVR, and then maybe SAVR with TAVR. And I'm trying to understand, and especially thinking about durability of the valves, why not switch that to SAVR and then TAVR in SAVR for the younger patient, number one? Or are we going to have to teach our surgeons how to explant TAVR devices? So where do you stand on that?
Well, first, I would certainly say, in answer to your second questions, yes, we have to really develop better ways to be able to explant the TAVR devices. The first two surgical series were disappointing in terms of increased complications associated with explanted TAVR systems. But I think we're in the very early stages of that, and I'm confident that we're going to learn how to be able to do that more predictably. The younger patients are at their most active state. And there's no question that we can achieve comparable results in these younger patients with TAVR versus surgery. I also believe that we're going to learn how to do TAV and TAV as a second procedure very effectively. And I would reserve the sole surgical procedure further downstream as opposed to upstream. And I honestly believe that the durability, if it's different than surgical bioprosthetic valves, will be marginally different. So I'm not assuming that those differences are going to be great. And my greatest goal is to tell patients that during the course of your journey with valvular heart disease, you'll only need surgery once. If you start with surgery first and then do TAV in surgery, then your third procedure is going to end up being a second operation in an older person as a redo. And I would rather not do that.
No, I think it makes a great deal of sense to me. I certainly believe that. And so we have this great panel here. We have, I believe, Azim, Didier, and Holger. What do you guys think about what Marty just said? And, we heard about asymptomatic, moderate AS, pure AR, bicuspid aortic valve. Is there anything that's left unturned here? Didier, who should get SAVR?
I think that's a very important question, Roxana. So first of all, thank you, Marty, for this beautiful keynote lecture, and we learned a lot as usual. So I think it brings us all every time to the question of age, because if we expand the indication towards moderate or asymptomatic severe AS, we're going to end up with younger patients. So I love the idea of getting a sequence, understanding the sequence that's more appropriate for a specific patient. But Marty, do you have any opinion on devices that are going to kind of soften the leaflets, avoid to implant the implantation of any kind of device, whether it be a surgical valve or a TAVI device? This way, you can provide additional time for the patient before surgery, because I truly believe that surgery is going to be part of the equation. It's going to remain. We know now more or less who is a good surgical candidate, who is a good transfemoral TAVI candidate. But in the future, do you think that there is going to be a place for this type of devices that avoid to implant a stent or a surgical bioprosthesis in a young patient?
Yeah, I think that's a great question, Didier. There's all kinds of new technology that I think is going to empower us in the future. If there's anything I've learned over the last 20 years, don't discount innovation as affecting some of our thinking as we go further along. First, there is a whole host of new leaflet technologies being developed, both for surgical and for transcatheter valves. They're going to be non-thrombogenic and are going to have greater durability. That will happen over the next 5 to 10 years. We're not factoring that into our equation, but that will be certainly part of our future. There are leaflet remodeling technologies that are being explored. I have an FDA call later this morning about one of those that will remodel the leaflets in such a way that at an early stage you should be able to improve leaflet flexibility and potentially delay the need for the first valve replacement, either TAVR or surgery. And even though my slides were a little simplistic. There are clear indications for which patients are going to be preferred for surgery versus TAVR, and there are going to be certain patients, clearly, that you're not going to want to do TAVR because of a variety of anatomic reasons, and where surgery is going to be preferred, which is why I do believe it's pretty accurate to say that even by 2025, that at least a quarter of the patients will require surgery. So I'm not anti-surgery. I just believe that redo surgery is something I'd like to avoid. And when people are most active, that's when they derive the most benefit from a less invasive transcatheter procedure. And it's the younger patients who are in that category.
Well, I can tell you that the younger patients are looking for a lesser invasive. They want to get back to work. They want to remain active. Holger, where do you stand on bicuspid aortic valve? You heard Marty's talk on this. We know that there's some aortopathy. There are some phenotypes that just may not make it to TAVR. What's your view there? And maybe we can have a little bit of a discussion on bicuspid before we get to the asymptomatic and moderate AS.
Yeah. First of all, Marty,
Holger.
great talk. So it was amazing to listen to your talk. It was really great. And also that you identified the open fields. With respect to bicuspid aortic stenosis, so this is what we surely do also interventionally at Leipzig. But nevertheless, we always have a hard team discussion on this. And as you already mentioned, so there are specific anatomic criteria, mainly calcification, maybe also left ventricular outflow tract calcification. And then always we have to look for the comorbidities of the patient, and then we will have to decide which will be the best strategy for these patients. That's the reason why we nowadays do it more on an individual basis to make the decision if we go for TAVR or maybe also for SAVR. Honestly, I also believe that we need randomized trials, even more in this field. And nevertheless, currently we have good data that it can be done in selected patients with the appropriate anatomy.
No, it's great, and I want Azim's. We have to go to Didier's talk, but Azim, new devices. It seems to me like we have these 2-3 incredible valves that everyone's using pretty much as de facto, but it sounds like with this kind of a venue in front of us that new devices will be coming forth. Where do you stand on that?
Absolutely. Thanks for the question. Can I just say to Marty how much I love this new terminology, sequencing? It's really catchy, and I think we're all going to be using it and discussing this word sequencing. I absolutely love it, Marty. So as far as new devices, I think the bar's been set really high, Roxana. If we look at the two main valves we use, I think any new device is going to have to be at least as good when it comes to PVL pacemaker rates, and then start offering something more, right? I don't think we've resolved all the issues when it comes to the current technologies, so I still think we need to do better with pacemaker and get to low single-digit rates with pacemaker. I still think we need to eliminate mild PVL, and that's important. We need to know more about durability, and then we also need to now kind of go to the next step, which to me is something like commissural alignment, which potentially will give us better durability and better coronary access. So I don't think as far as iterations of devices and new devices, it's all done. We need to continue to iterate and adapt our devices. I think there are two probably unmet areas where we still can do a little bit better, and for me that's bicuspids, and then to have technologies for pure aortic regurgitation like Marty mentioned.
No, I think you're right on, and listening to that talk, I think it perks up everyone who's in this arena as innovators, and I think we need more, and we're looking for more. But that sets us for the next talk. Are all valves created equal? And that's where Didier Checher is going to take us through the next talk. Didier.
Thank you, Roxana. So are all valves the same? This is a great question. And as it is a controversy, I will try to keep my talk quite short so as we have a discussion, because I'm really looking forward to hearing your perspectives on that. But I have to to tell you what I think, and this is my opinion. The answer is clearly no. I don't believe that all valves are the same. Why? Very simply, because not all the patients are the same. So we really need to try to understand what is the device that is going to be the more beneficial for the patient. And not all the TAVI devices are the same. There are different technologies, and this is meant for a purpose. So we need to understand that. So I will start for once with my conclusion. Not all the valves are the same. And we will see at the end if you agree on it. So the first thing that we do when we try to decide on a device for a patient when it comes to TAVI is to analyze the aortic annulus. And for the vast majority of the devices that are available, the annular range is between 20 and 27. Below 20, we have a couple of devices that may fit patients like that, and above 27, there are very few devices that can reach that target. So the vast majority of the devices cover 20 to 27 millimeter annually. And we did a retrospective analysis in Toulouse. And what we saw among all the patients that have been treated is that close to the mean aortic annulus diameter is about 25 millimeter. And so let's say that roughly more than 80%, 85% of the patients can be treated with either devices. So we need to find additional items to understand and to select the device for a patient. So we like that concept of patient-tailored approach. So we try to analyze the features of the aortic root, of the peripheral vasculature, the anatomy of the distribution of the leaflets, the amount of calcium, if it is a bicuspid, a pure aortic regurgitation, all these features that we all know given the experience that has been gathered so far. But this is really driving the device that we're going to select. We can't say, and I hope that we agree on that we can put any type of device in any bicuspid, in any pure aortic regurgitation, because we've learned that this may not work for a specific patient. So if we start quite briefly with horizontal aorta, the definition most of the time is when you have an annulus that has an angulation of more than 70 degrees. So this is quite an extreme angulation that exposes the patient to a risk of malpositioning of the TAVI device, and most importantly, a perivalvular regurgitation, despite that the fact that we have now devices with skirts, wraps that prevent regurgitation. In very horizontal aortas, it can be difficult. We have learned through all the experience accumulated how to treat it with self-expanding platforms like the core valve, but we have to agree that this is really challenging in some situations. So I would say that for this horizontal aorta, self-centering devices like the SAPIEN 3 device or the accredited device makes sense. The Lotus Edge is not anymore a player, but if we want to make it easy, we're not going to select this type of devices. So when it comes to calcific aortic root, quite intuitively we understand whether the calcium location will be at the level of the leaflets, be a calcium chunk just at the level of the aortic annulus, or a diffuse and extensive calcium burden at the level of the LVOT. There is a risk of annular rupture and a risk of perivalvular regurgitation for the patient. And in the vast majority of the patients, we're going to use a device that has sealing properties appropriate for this type of extensive calcification. In the past, I used to prefer the Lotus Edge for this specific situation, but now any kind of device with a wrap makes the job. If I think that the annular rupture rate is quite high, I'm not going to select the SAPIEN 3. But for the vast majority of the patient, the SAPIEN 3 is my preferred device when there is a heavily calcium load with a limited risk of a rupture when it's not a chunk of calcium very located at the level of the annulus. So we've talked about the bicuspid. Bicuspid is really a burning issue that raises a lot of debate, a lot of concern. We are getting more understanding about how to size bicuspid aortic valves, how to analyze the anatomy of the patient, and that CT scroll technique is now standard of care to understand the leaflet distribution, the distribution of the calcium, because as we've seen in the previous talk by Marty, that when you have extensive calcium at the level of the leaflets and the raphe, this is going to hamper the outcome for the patient with an increased mortality when it comes to follow-up. So clearly analyzing the anatomy of the aortic root makes sense. And we have now more understanding about the sizing. And when we conducted the Bavard registry, we could provide data to understand the concept of landing zone configuration, starting from the annulus and scrolling upwards at the location of the leaflets to understand what is the configuration of the landing zone. And in the vast majority of the patient, you meet a tubular or a flared configuration for which the annular space sizing makes sense. And it's only in tapered configuration when you have the supraannular region that is smaller than the annulus that you may slightly downsize or utilize the minimal amount of oversizing for that. We have data coming from the TVT STS registry, extremely reassuring data with the SAPIEN-free platform that was utilized in a quite significant number of patients. And when in this match analysis with tricuspid patient, the conclusions were quite reassuring. We first, for this balloon expandable platform in quite young patients, 73 years old, with at intermediate risk, a survival that was similar between tricuspid and bicuspid patients at 1 month and 1 year, but with an increased risk of aortic root injury and conversion to open heart surgery. Even if it's limited, probably that's something that we have to keep in mind and better analyze the aspect of the ascending aorta, the presence or absence of any aortopathy when it comes to a device type selection. And quite early signals of potential risk of higher stroke rate with this device in bicuspid patients. John Forrest has led a very interesting analysis on low-risk patients treated with the self-expanding platform. We've done the same thing with the within the Bivalent X registry, with a prospective registry with contemporary techniques in terms of sizing, pre-dilatation, repositioning, trying to understand what is the appropriate amount of oversizing in bicuspid patients. And we've dedicated core labs, CT core lab, echo core lab, a CEC. And what we saw is that it confirmed what was proposed, what was demonstrated in the low-risk trial with very large EOAs, more than 2 centimeters squared with this platform. Virtually no moderate or severe regurgitation when the pre-dilatation policy, repositioning policy, and even post-dilatation is applied. The final regurgitation rate is really low for this platform, so very reassuring. So for pure aortic regurgitation, I would say that, to my opinion, once again, not all devices are equal. And I would say that if we accumulate data with the ENA-valve should be the first choice for pure aortic regurgitation, because we have seen with the OVO platform, whether it be the Evolut or the SAPIEN-free, that the procedural success is not that high, and we have a high complication rate with a high mortality rate in this population of pure aortic regurgitation. So potential, there is a lot of expectation with the ENA-valve in this indication. So if we move to a smaller annuli, clearly we have to understand that there is in that subset of patients a higher risk of patient prosthesis mismatch. And if we analyze the data from the TAVI small registry comparing self-expanding platforms, the PPM rate is quite high, but supraannular designs have an advantage as compared to intraannular valves. So potentially in small annuli, a self-expanding supraannular design makes sense, whether it be the Evolut or the accurate platform. For valve-in-valve, we have the same feeling that in small anatomies, with most of the time valve-in-valve, we are dealing with prosthesis with inner diameters below 21 or 23. And so in this situation, we can see that there seems to be a small advantage of the self-expanding platforms in terms of final gradients, final hemodynamics, but this was in the area before all the valve fracturing, all the knowledge that we've gathered in terms of preparation of the bioprosthesis to get the better hemodynamics. So we need new data to explore that. We need new comparisons to explore that. So we'll see in the future if there is something to do for valve in valves. So I have the now to quite briefly, we will try to see what we have in the literature in terms of comparison of devices. There are a few studies, but I do believe that we need more contemporary data. If we come back to the CHOICE trial, CHOICE was randomizing the patients between SAPIEN XT and core valve and demonstrated a clear advantage in terms of device success for the SAPIEN XT with less regurgitation and less pacemakers. But this was with previous iteration of the devices and techniques, procedural techniques that have been improved. And so we need to repeat this type of comparisons with contemporary devices and contemporary techniques. We had the kind of insights and more understanding of the within the SCOPE 2 trial of potential differences between self-expanding platforms. And the ACCURATE Neo was compared to the Evolut R, Evolut Pro self-expanding platform. And clearly there was an advantage, we have to be honest, there was an advantage of the Evolut platform because in terms of regurgitation, the non-inferiority criteria was not met by the ACCURATE platform. So we will potentially see different results with the ACCURATE Neo, but for the time being, that's what we have. So finally, I have the great pleasure to be PI with Roxana and Howard Ehrman of the SMART trial. And SMART trial is definitely the type of trial that we want to see. That is going to be a head-to-head trial with new techniques, new iteration of devices, in specific indications, because I do believe that's what we need is to understand if a device is better suited to a patient in a specific anatomy. In SMART, we will tackle a small annuli, less than 430 millimeters square, compare the SAPIEN 3, SAPIEN 3 Ultra to the Evolut Pro and Pro Plus. And so more than 700 patients will be randomized. The first patients have been included. So we will have to wait to see if there is a difference in terms of hemodynamics, in terms of performance at 1 year with between these platforms. So to conclude, I would say that I don't think that all valves are the same, but I'm looking forward to hearing your comments. I do believe that a patient-tailored approach should prevail, so we cannot say that we can't use only one device for any kind of anatomy, because I think it doesn't make sense in contemporary practice. We should really try to tailor a device to the anatomy and to the patient that we are treating. So specific anatomies could favor one design. We have to wait for long-term durability data that are going to add more to the discussion and the understanding of the device selection. And randomized head-to-head trials with contemporary platforms and contemporary techniques are really awaiting. So thank you for your attention.
Thank you, Didier. That was a fantastic talk talking about not all valves are the same, and obviously lots to look forward to. We've got Lars waiting for us in Copenhagen for a live case. He's ready, but I want just a few minutes, and I know you've got to go for your live case, so we'll go quickly, and I want to go over the poll. So lots to do before the live case. Marty, you're here. What did you think about I think you probably agree that not every valve is made for every patient, and that we need to have more valves so that to figure this out. What thoughts do you have here?
Absolutely. I agree completely with Didier. It's foolish to think that a single valve is going to fit all patients and all anatomies. So I think having a diversity of valve technologies is going to simply make us better. You remember, Roxana, when we started developing new devices for the coronaries, we had this concept of a multi-device lesion-specific approach. Exactly. Well, the same thing is true with valvular heart disease. Mm-hmm. There are different patients, different anatomies that will favor one design versus the other. Now, do we need randomized trials in every one of those? Probably not. But I think some of the targeted randomized trials that people are contemplating are certainly interesting. They'll inform us, and it'll provoke us to continue to iterate the technology. So Didier is absolutely right. I'm completely concordant with his approach.
No, and I think we're very proud to see this large randomized trial between the two current platforms in small annuli, and I think we're going to see a lot more. So let's go look at the poll. Didier, I know you're leaving us, so thank you so much for your wonderful talk. Thank you. Transcatheter heart valve durability remains a major limitation. Look at this, Marty. 73% think that. Holger, what do you think? Is this the biggest limitation? Have we not shown the durability data good enough?
Yeah, honestly, I'm a little bit surprised. I probably belong to the 27%. So at least in comparison to surgical valves, I do not believe that there's a big difference. Maybe it's an issue with respect to younger patients when we treat them, but nevertheless, as Marty has nicely shown, so we can do valve and valve or valve and TAVR. Honestly, I do not believe that this is a major issue, but we will see. Probably we have to convince the people with more data, and that's probably our task that we have to do now.
Yeah, no question. Well, Azim, any last words before we go to the live case? Lars is waiting. Azim, you're muted.
I said thank you. I would just make a comment about durability, and similar to Holger, I don't think it's a major limitation. I just think we need more data. All the data we see so far is so promising, and we are starting to see long-term data. But many of our colleagues, we have to remember that all of us who are talking here are interventional cardiologists. Many of our general cardiologists still want to see this sort of 10, 12-year data that on these valves. And so we just need to provide them with that data. But I think the reassuring thing is we're just not seeing any warning signs so far that there's early failures in a large amount that would make it concerning.
No, thank you so much. Well, this has been a fantastic session. Thank you, Marty, for being here with us. You're more than welcome to stay with Lars's live case. But let's show the next poll before we go live. This one is different. Catheter-based left atrial appendage closure could replace oral anticoagulant drugs in patients at low bleeding risk. Yes or no? Please vote. Okay, going to Copenhagen live.